A warm welcome to all. Today we have the fifth episode of FCPI podcast, and I'm Harita Rajakrishnan, and I'm the host for today's episode. So, as you all know, throughout the podcast series, we have discussed the different arenas of clinical pharmacy, be it infectious diseases, transplant, research, and as you know, the latest episode we had on developing a leadership skills among the critical care, not critical care, clinical pharmacy, clinical pharmacist as such. So today we'll be diving into the world of critical care pharmacy. So as you know, as a critical care pharmacist, it is imperative that you have a deep understanding of pharmacology, clinical decision making, and also the responses should be so rapid that it actually changes as per the patient needs. So I'm very much, it's my honor to actually have the two guests for today. So they are critical care pharmacists as such. And welcome to both Dr. Abde and Dr. Idris to the session. So, Dr. Abde is,
Thank you so
he
much,
has
Anita.
an,
Thank you so
yeah,
much.
welcome. So, Dr. Abde has over 4 years of dedicated experience in critical care and also hands-on experience in ECMO dosing, TDM, and CRRT. He has also spearheaded the antimicrobial stewardship program for Kingsway Hospital, Nagpur. He also has experience in pediatrics and neonatology specialty. And currently, he's working as a clinical pharmacist at Medcare Hospital, Sharjah. Welcome, Dr. Abde. And next, we have Idris. He is currently working
Thank you
as
so
a
much.
lead clinical pharmacist in Symbiosis University Hospital Research Center, Pune. He has 3 international publications in his name, and he has also been awarded as a third position best paper in Clinical Infectious Disease Society of India Conference 2023, and also second position as best poster in FCPI conference on infectious diseases in critical care, which was held in Calicut in 2023. So once again, welcome to both the speakers.
Thank you so much.
Thank you.
Yes. So as you know, so today we'll be discussing about critical care pharmacy. So before speaking about critical care pharmacy, definitely we all know that it's a journey from PharmD, and then you do your internship, and then you actually choose your specific areas of interest, isn't it? So definitely it's not an easy journey. Obviously, we might have had doubts, we might have had questions. Like at some point of time, we all have had that. We all have crossed a stage where we actually second guess, okay, is this what I need? Or, okay, fine, I'll go ahead with this. So a lot of things might have, we all have encountered definitely throughout our career. So we'll just start with the most basic question. That is how did you end up choosing PharmD, and how was the journey, like being a student and through your internship process? How was that? So I just would like to start with Abde. So please, Abde, do share your journey, like from PharmD to clinical pharmacy.
Yeah, thank you. So it was a very different thing. So my father already was a pharmacist, and I could see him knowing about a lot of drugs, medications, and everything, and a bit of pharmacy background in my relatives as well. So then we were searching. I was in the same mind to go with pharmacy, and we were searching, going through newspapers, and I saw one day this advertisement for a doctor of pharmacy. And we searched more about it. Bachelor, we already knew what all things were there, but this new course just caught our eyes. And we started searching, and we saw what all opportunities there could be. And I had in it me somewhere that I want to do something in clinical practice, maybe related to hospital. So combining this pharmacy passion with the clinical implication, I think so that was the thing that made me choose PharmD. So I took admission. I went to Amravati, the Government College of Pharmacy for 6 years. I studied there. Uh, it was a different course. I mean, really different. Like I had to study pharmacology, therapeutics. I really liked those subjects during my time, and I like studying these subjects. And it was really new for me, uh, knowing pharmacy and the clinical implications, and knowing more about the hospital working. So that is how I chose PharmD, and here I am.
Great. I think Idris, you also have a similar background, isn't it? Even you come from a
Yeah,
long, I mean, you have a long family background of
yeah,
pharmacists as
yeah,
well.
yeah.
So
Sim
even were you sure that you wanted to be a pharmacist, or did you have a different career option in mind, and then, maybe your son pressurizing from the family, and then you ended up being here? How was it for you?
Even like just like Abde bhai, even I had a similar background of pharmacy. Like frankly, we have a pharmacy shop in our hometown since 75 years now. Before we used to do Ayurvedic practice, and now modern medicines we are doing. So we had even my family have lots of pharmacists. My brother used to practice in pharmacy in Dubai. So this is how I get to know. I didn't know that some kind of course like this family exists until unless my brother told me that as he was practicing in Dubai, he told me that this is a very good course because I've seen many people from around the world coming to Dubai and getting a good job opportunities here. So I thought I should explore this area, and the thing which attracted me the most was the that doctor prefix. So so we all got attracted toward it. So it was a good course. I had good learnings into it, and of course, I had many different minds and doing MBBS and everything, but finally, I landed up in PharmD, and it was a amazing course. If I can say, it was meant for me.
Sure, great. I think the doctor prefix is a very right point you said, because most of us, I think we will have to agree. At least 90-80% of us have definitely approached PharmD mainly because of the doctor prefix. Especially, I think
Yeah,
most of
it
them,
was a very plus point.
yeah, it was a plus point. Like it's actually what two in one maybe, because we might have had the maybe we wanted to pursue MBBS, but then we tried, we went for entrance coaching and everything, and then we failed there, and then we wanted something in the medical field. Yeah, and this was like
Yeah,
all in one package where you're actually working in a medical care setting, and plus you're actually getting to interact with the patients. You also interact with the clinicians, so you're basically part of the whole team. So I think that definitely has a role there. Okay, so now that
yeah,
you have
yeah, yeah.
mentioned
Huge
about,
role.
yeah, definitely. So about the PharmD and about being the clinical pharmacist, okay, fine, the journey is clear. But how, I mean, what was the trigger of, or how did you end up choosing critical care? Because we have different departments, different areas where we can actually work. And most of common is actually oncology and infectious diseases. I think currently those are the mainly the fledgling areas of clinical pharmacy. So, Abde, I would like to start with you. So, how did you know that you wanted to be in critical care, and where your internship posting mostly in critical care setting itself? And is that how you wanted to be a clinical pharmacist in critical care, or was there any other triggering points?
Yeah. So I think when we just started our education and the degree, uh, hardly we knew anything about it. Like how is going to be the job? What are going to be our roles? I think so that time it was very in the grassroots levels that clinical pharmacy was just started. And so it was not in my internship, but in my externship that I knew about where I was exposed to ICU. So in the externship, my half day was in ICU and half day in oncology ward. So again, there was a fight in to choose which side I wanted to be on. Then it was just that the ICU practice and the way I see my mentor practicing in an ICU, that made me think about it. And luckily, after I finished my externship, I got this opportunity in my hometown itself where I got in an interview with the lead intensivist of a very new hospital. And it was supposed to be a very good hospital, the modern art, state of the art hospital, and everything. And luckily, I got this interview, and he asked me all the relevant questions regarding critical care. But at that time, I was just very new. I had just 2 months of experience from an ICU. So I knew the basics, but I didn't know much about the critical care part in that detail. So the interview was not that great. But then, I thought, yeah, I need to improve. I need to learn more about critical care, about ICU, because he was looking for a clinical pharmacist that would be working in ICU. So he offered me an observationship, and then I joined. And since then, I've never looked back. And ICU just day in, day out, seeing the different cases. And it was not just like touching one specialty in critical care. It's so many specialities together in each case. So it's not just restricting to one particular specialty. Oncology was also there. So you go get patients, oncology patients, you get nephrology, every case that you see. So that made me think that, okay, I want to be master in all the topics. I want to master them. So I think so critical care would be a great platform. So yeah.
I mean, you're right on that point because if you are an ICU pharmacist or critical care pharmacist, it's imperative you have knowledge about all the things. I mean, it's not just one specific thing you're dealing with. You need to be aware of everything that's going on, right from the diagnosis, the fluids, whatever is there. You need to be aware of that. It's not like you're treating one particular condition. You're treating multiple conditions at the same time because one patient will be having some other diagnosis or some other drug will be going the other bed, they had some total different situation. So yeah, it's quite concerned. I mean, Idris, how about you? So as Abdel rightly mentioned, it's a pretty stressful situation. Actually, it's a stressed work environment. So how do you find critical care? Is it like how do you manage the challenges, and what are the challenges when it comes to discussing with the physicians about the condition and the acceptance rate there? How do you feel it?
So, for me, the ICU experience, the starting experience was very different. Like in my case of internship, I had not much of ICU experiences in as of my internship. But when I landed up in Jahangir Hospital, which I was previously practicing, so my seniors told me that you have been allotted an ICU ward, so you have to go and take the rounds every day. So I was very new to the ICU setup, and when I started rounds, I was very scared actually before because there are in the ICU like lots of machines, lots of noises coming and everything. And I was like little after that, it's a very high level of practice. I won't be able ever to catch it. But it took me 6 to 7 months, and I was wrong that I'm not that level. It realized me later that we are on the same level. We have same understanding, and slowly, I got used to the real practice of critical care. So it is very important for every clinical pharmacist, like you just if you are stepping into some kind of specialty, you have to observe the things. You have to like go through the things for 6 to 7 months, and then look how you're setting this, practicing the clinical things there. So within the span of 6 to 7 months, I learned many things regarding critical care pharmacy, like how clinical conditions are different from ward here. So once I started practicing, I got to get some gaps, like what all are the gaps, like gaps in cases of dilutions, gaps in case of drug interactions, gaps in case of reconciliation. So there were lots of gaps which we need to fill as a clinical pharmacist. So my experience of clinical pharmacy in critical care was very like abrupt, but eventually I learned when I went to the ward and I got a lot of interest in critical care, and eventually uh, I contributed a lot in this span of 3 years, I feel.
Yeah, great. As you said, it is that there were a lot of challenges you faced, like when it comes to dosages, when it comes to fluids, when it comes to medication reconciliation. There are a lot of things, a lot of loopholes that can happen actually in critical care settings. So, among all these, which did you find the most challenging? That is like compared to being in the ward setting or compared to being in the maybe in OP setting also. What is the one thing that you find more challenging among the critically ill patients as a clinical pharmacist?
Okay, so for critically ill patient, as a clinical pharmacist, I feel that the most important thing can be drug interactions as of my
Mm,
practice, because I used to see lots of drug interactions in critical care area, and drug interaction is something which makes a clinical pharmacist very special in a critical care area, because the drug interaction is the only part which is solely done by clinical pharmacists. Like other
mhm,
things like dilutions can be told by a doctor, but no one used to tell drug interactions in a critical care setting than a clinical pharmacist in our settings, in both of the settings like this.
Mm.
So they are even the physicians, even the nurses they are more interested when I used to tell them that these are the drug interaction, just change the frequency or just change the doses. So these all things practically happened to me when I was in critical care area. So drug interaction is the first thing I feel that is a good opportunity plus a challenge for a clinical pharmacist. And other things like if I say if we say like that warfarin, like if we say rifampicin, we use lots of rifampicin in critical care area. We cannot give it with antifungal drugs. So there is some guideline telling that if you have given rifampicin to a patient and you want to start them on an antifungal drug, you have to wait for 2 weeks.
Mm.
So you have to know all of these things. You have to read the guidelines and you have to implement drug interaction, not just on a superficial level, but a level of clinical practice where there is an impact of a drug interaction.
Mm.
So that is one part. Another part is drug-food interaction is also very important in the critical care area because when there is a guideline, there is a compliance of NNPT. You have to monitor drug interaction in the hospital setting. So we used to I actually we didn't identify a drug interaction, but we used to prevent it by taking the trainings of the dietitians. Like we
Mm.
used to take trainings of the dietitian on different drug content like warfarin, vitamin K rich foods like green leafy vegetables and everything. So periodically, every quarter, I used to take trainings of the dietitians on drug food interactions. Like I used to take one like cardiovascular drugs and its interaction. Then on the next quarter, neurologic drugs and its interaction. So and the paper I used to refer for this drug interaction training was written by a pharmacist. So
Oh.
there are many specialized PharmD in the Western countries where they are also specialized in the nutrition part. So they
Mm.
have written those papers, they have published those papers, and based on those papers, I used to take trainings of the dietitians. So I think drug interaction is the first thing that any critical care pharmacy must know.
I think it's an excellent point which you mentioned, where you actually train the dietitians here, because most of us, we are very much aware that we need to train the nurses regarding the right administration, dilutions, and everything. Because actually, they will call us. Because once we go there on a regular basis, they will start calling us and they will ask each and everything. Other the like in what the diluent, I mean, what diluent should we use for this drug? What is the dosage and how in what ml per hour should we give the drug? So this thing where you mentioned about the dietitians, I mean, the training the dietitians is actually a very relevant point, I feel. Abde, what about you? Have you been involved in such setting where you had to train the dietitians regarding the different drugs or anything? Have you been, I mean, in your hospital, do you have the setting?
Yeah, absolutely. During the TPN or any enteral feed they start. So I would really collaborate with them on how much of protein intake or carbs intake are they going in, what kind of setting the patient is right now, and the calorie intake, calculating those. The doctors would discuss this in the rounds. And I started reading all the Aspen guidelines and everything just to get up to date and obviously collaborate with them and see which all drugs we can crush, not crush, can be given with
Mm.
food, without food, after food, whether with the RT or any peg feeding is there. So a lot of time collaboration with the dietitians, yes. And plus one more different collaboration that I would like to add with would be the physiotherapist. I mean, how would be a clinical pharmacist collaborating with a physiotherapist? So I would every day ask them, hey, are you mobilizing this patient or not today? I want to stop the anticoagulant.
Great.
So yeah,
Very, very, very unique.
Yeah, that's very unique approach. I was finding
yeah,
training the dietitian is a unique approach. Oh, this one is more. This one is even more.
You have opened
Great.
new doors.
Yeah,
yeah.
great, great
And
way of learning.
and your
Yeah.
challenge with drug interactions is very true, Idris. I mean, I would like to share one case of drug interaction that was in my initial period. So then we had a case of a trauma patient with blunt abdominal trauma. So he had abdominal resection surgery. So this was also new surgeries coming up. Then new terminologies like short bowel. Okay. Then SIBO, like small intestinal bacterial overgrowth also. So many complicated case that was. And he also had psychiatric issues. So I think so you might be thinking, where am I going with this? So yeah, he was on antidepressants and everything. And plus for the bowel, we were giving him metoclopramide. Plus, I think so he was very agitated and everything. And we started on haloperidol. And everything was on control. Surgery went well. There was the surgeon says from our side it's all good. And suddenly he started having fever, and an unexplained fever in ICU is one to look out for, and it puzzles everybody what could be the source. So we are searching. First thing you go for infection, but he was covered well with the antibiotics. He was responding to that. The counts, the CBC were not directing towards that. So now there was something else that is going on here. And my intensivist asked me to check the drugs. Is there anything that is causing this fever? So, like normal practice, I put in the drug interaction, all the medication that he was in. And well, to my surprise, there were three, four X category interactions telling that this could be an MS. So immediately we started removing those drugs, and voila, in 2 3 days, it's settled. So yes, so those things, like it could be those drug interactions that can make a difference. So every day you have to keep on check and make sure that no drug interactions like these occur.
Also,
Mm.
I would like to add one more point here, that even I had an experiences like like all not all drug interactions are bad. Some are good drug interactions also. If you see like voriconazole and omeprazole, actually it increases the AOC of voriconazole when we are actually not getting the trough levels of voriconazole. So you have to see things like in that way also, that some interactions may not be they are harmful, but some interactions are good also, like omeprazole and voriconazole. So this is the new thing. This is the thing which we need to consider. Another point is the Abdev bhai just said that the the part of crushing the tablets. It is very famous in the hospital. And in critical care setup, you should know the pharmaceutics part of your tablets and capsules. It is very important. Like you know which all tablets should be crushed. Many times, the doctor used to ask me, "Can we crush film coated tablets?"
Mm.
They used to call me and they used to ask me. So we know that film coated tablets, of course, can be crushed. It has nothing to do with the its release. So it is a very basic thing, but we used to get lots of queries of this in the critical care area. And even consultant used to ask me. Even I had one query from a consultant: Can we give intravenous vancomycin orally to a patient of C. difficile infection? So you have to know the pharmacy, because vancomycin tablets was on market shortage at that time. So they used to ask me that, can we give an powdered form of vancomycin? Will it be useful? So I read it, and yeah, I told them it can be useful. So the basic thing, the point which I want to put is, you should know the pharmaceutic part, because it is the core of a clinical pharmacist. Actually, what is the difference is, we start with the clinical setup, and then we go to the pharmaceutics part in clinical pharmacy area. But the internship should start with the pharmacy thing, the pharmaceutical thing, and then slowly we should go to the clinical things. That is that thing I think we should need to integrate in clinical pharmacy practice.
Yeah, exactly. That's a good point. Because pharmaceutics, I think we learn in our I don't know, every formulations, but apart and all, we just forget it very
First year,
soon. That's,
first
yeah,
second year,
first
yeah.
year. Yeah, and then we do the practicals, and then we are like, once the exam is done, okay, fine, now we are done with it. Now that we are PharmD and now we are going to be clinical pharmacists, we don't have to remember all these stuff. Let's just think about other things. And then we just forget it
Yeah.
altogether. But actually, here we really, I mean, it's not just in critical care itself, even in the wards also. There's something that do, I mean, even the sisters and nurses, they do the same thing. They just crush the tablet. They're very much interested in crushing the tablet, because once they see that the patient is not taking orally, okay, fine, let's just crush it and put it in the RT and come on, let's give them medicine. So I think that level of knowledge is very important. Like, it's a good point that you have mentioned here. So the similar way, so as you mentioned about the drug interaction, I think the next challenging thing will be medication reconciliation, especially I think in critical care, because what happens is that many times the patient might be knowing because they might be very much independent and they'll be taking all the medicine. But once they are admitted and they're in such situation where they can't actually tell you what medications they were on, then we have to depend on the bystanders. So as you know, each day we'll get new bystanders will be keep coming in,
And
maybe relay, sister, brother, and then they might have no clue on what the patient is on. So have you had any experiences like that where, you were like, you found it very difficult to reconcile the patient's old medication, and because of that, maybe some situation or any other issue that you had encountered because of the same update? Maybe we'll start with you. Can you recall any such events?
Uh, yeah, so in my practice, I used to always go with the drug history first,
Hmm.
uh, taking those old medications, and there would be such a times when you're not able to recognize which tablet this is. So a lot of
Yeah, yeah.
companies,
The most interesting
tablets,
part
and
is
all
that,
those things.
yeah, when we ask them what medication is on, they will just give you a lot of packets of medicine,
Yeah,
and
yeah,
it's like all
100%.
broken. It's like half
that's true.
broken and everything. You won't even find the name in it. I don't understand how they expect us to understand the medicine. It's just a white tablet, and sometimes when we ask them, it's like, he
Yeah.
used to take a medicine which is like pink color, small one that he used to take. So I like many a times I face that situation.
Yeah, so interviewing them in a different way and in simple manners where they can understand, like, okay,
Mm,
are you having troubles with sugar, blood? In your native language, also, you can speak and
yeah.
try to find out, get that information from them. And at times it is very difficult. And I think so. One thing that we don't find that much common in India is finding out whether they are drug abusers also. So
Mm,
in ICU, it also matters a lot where we are giving opioids. But if somebody is a drug abuser, it won't come clean. They won't come that clean. So it's very difficult at times to get to know that. You have your tricks and to learn that from. So I think for the doctors and every day you kind of see from the physical examination that they do. So you get those ideas from also. And reconciliation, I feel, is not just limited to the admission in ICU. It's also in transition of patient. So really taking in when the ICU from the ICU when the patient is being shifted to ward. So that is also one part where you have to do the reconciliation of medications, which all drugs need to be continued. After patient is getting shifted and how they will be monitored. If suppose there are some difficulties in doing so, uh, I would suggest not to shift that patient unless until the drug is stopped. So that is also one reconciliation point and when the patient is getting discharged. So it should always be a continuity of care. And critical care does not end with just the patient being shifted from ICU. It should be probably, getting involved more with the patient even till they are discharged or even after the discharge. And it gives such an immense pleasure when that patient comes back for follow-up and you see that patient has improved so much. So a lot of errors also can happen during that time. And again, the patient might land up to an ICU. We have seen so many cases of readmission. So it is very, very important and crucial that reconciliation is giving a lot of importance, not just during the admission, but also when the patient is being transferred and discharged also.
right. Totally agree with you on that point because what happens is that many a times when the patient is shifted out, we just tend to lose the follow-up with the patient because now that, okay, fine, now the patient is gone to the ward, we may, like what happens is that most of the drugs will be ongoing, many important drugs and maybe even the sedatives and a lot of antihypertensives, like a lot of drugs will be ongoing. And what happens is that since the doctors posted there, maybe they won't be well aware why the patient is actually on this medicine, even the anticoagulation part as well. Maybe some bridging will be going on, but still something else will be happening there, and then there will be change in INR levels. But sometimes what happens is that it tends to be missed out. So it's very important that we actually check the medications once the patient is shifted out as well, and we have a right follow-up with the patients. Very good point you mentioned. Idris, how about you? Do you have any points to add on here?
So actually, I wanted to add one important point here that which I have seen in my practices. Like there may be other healthcare professionals might be doing the reconciliation part. Like mostly in our setting, it was done by resident doctors there. So they used to do medication reconciliation, but many times they were not used to connect it with the current clinical condition of the patient. Like they do not use to suspicion anything on the drugs, what a clinical condition the patient is currently having. So many times it was used to miss. Like we had got a patient, the patient was on warfarin, and the patient got admitted with the INR of 6 to 7 at that time. I remember. So nobody directed toward the drugs if it can be happened with the drug. But when I saw its medication reconciliation part, I found out that there was an antipsychotic medication which was interacting with warfarin, and it is shown to increase the INR6 of the patient because they were still ruling it out. I told them that this part should also be considered while other diagnoses are being made. So it is very important to not just take the reconciliation thing, but also connect it with the current clinical condition of the patient and like at least do a suspicion that something can happen because of drugs also. Because if the patient has come with has used to take a chlorothalidone tablet, we can suspect the patient might have got uh, low sodium levels on admission. So these all things which I have seen in critical care area, which you need to see that when the patient has some kind of drug and what all complaints the patient has come with. Of course, then there can be other diagnosis, but you try to correlate. If it is not relating,
Mm.
it's okay. But you have to do this practice at that point, I feel.
Mm. Yeah, right. So, is there any counseling that you do when the patient is in the critical care? That is when he is in the ICU or anything. Is there anything specifically you counsel the patients or bystanders about? How is the counseling part actually? Abdi, maybe you can start.
Yeah. So, counseling, I think the one major part is, I think so when, from the Western countries, they explain the patient each and everything about the disease, but nobody
Mm,
tells them about the drugs. In India, a lot of time it is missed. So in critical care also, it is very important to make aware the patient what kind of drugs they are and what might they be experiencing, any side effects. So I know it's possible for the conscious patients. Many times we are relieved from the duty of counseling a patient because many a time they are unconscious. So in conscious patients, I think so one should take an active efforts, and I have taken that sometimes to actively discuss with the patients what kind of medications they are on, what kind of results they're going to get from that medication, and what kind of side effects they're going to
mm,
might experience with this. So it helps them to better anticipate also for what is to be there, and not just know about the condition. So doctor is always telling about the conditions. Okay, you have so and so issues. It's going to take time to get resolved and everything. So a patient on opioid, anything else, pain, okay, it might take an hour or two to just get a pain relief and everything. So patient counseling, I think so in that way is very important clinical pharmacy in critical care in ICU.
mm.
In India, we usually have a practice that nurses usually counsel the patient regarding medication. This is the usual practice in India currently.
Yeah, what happened? Yeah, right. So what happened is that actually, yeah, even about the cost issues is also there when it comes to antibiotics and everything, because we know in critical care, a lot of medicines will be like there's like polypharmacy and a lot of important medicines that the patients have to take. So there's this thing with the cost issue as well. So we might have to counsel the bystanders about the same that, this medicine will cost you this much. And then accordingly, we may have to go for a brand and everything. So how about that, Idris? Do you regularly interact with bystanders regarding the same? Like, do you have to discuss about this financial thing? And then how do you manage, how do you tackle those issues?
As of my practice, I used to get all of these experiences, but since that was more of the consulting and administrative part, I had to
Mm-hmm.
like I had no
Yeah.
say in it. But we used to
Yeah.
tell them alternatives, like what all
Mm-hmm.
medication you can consider, what all low cost medication can be considered. If you have to, as a clinical pharmacist, you should know the brands and what the
Yeah.
pricing of it, which is very
Mm.
important. Because
Yeah.
many times consultant used to ask us like, इसका कोई दूसरा brand है क्या सस्ता वाला?
Mm. Right.
तो we used to tell them, sir, ये वाला देखे देखो
Mm.
अच्छा है. So this is the part which we can play, which I
Mm.
have experienced in my practice.
Yeah, I think it's very
On
important
that
that we
note,
actually, sure, sure. Please,
yeah,
Abdi, go
sorry.
ahead. No, no, it's
Uh,
okay. Please go ahead.
So, similar financial counseling I did do during the mucormycosis time when I was handling a little bit about the amphotericin B liposomal, and the
Mm-hmm.
prices had
Correct.
skyrocketed. Already the prices are way high, and if you have to give 5 to 6 vials every day, that's a huge lot of money. So
Mm-hmm.
I did used to counsel the patient that it's going to be expensive. Yeah, but most of the things is taken care by the administrative part. But a couple of times where it used to be an expensive part, yeah, we have to tell about them. And I would like to say that the current situation, the current job that I'm working in, a lot of things are play a lot of huge role in the financials. So it's not covered by insurance, but the things that are not covered by insurance, we have to talk with the patients, we have to talk with the relatives, the bystanders, informing that this is going to cost so and so. So are they willing to pay? If not, then we have to think of a strategy. Now, again, we have to have that idea of what else other therapy that can be chosen that can be cost effective each and every time, that how we can save a vial or probably manipulate those doses so that it can be a cost saving. So if we can see, if we can reconstitute a vial, give half dose, save it for later or something like that, if the dilution and the stability allows. So that is one also the key points where one needs to think regarding cost saving. Yes.
Yeah,
Of
that's
course,
so true.
this is also applicable in those hospitals which are free,
Hmm.
which provides free treatment. In that area, the part of cost saving and the role of clinical pharmacists is more, I feel, because they are interested in also saving the cost to themselves, to the healthcare institution only. So there can be a good role of this practice.
Yeah, I mean, it's true. I mean, knowing the different brands and actually knowing the prices of each medicine is also very important because, like you mentioned about amphotericin, especially the antifungals, they're like, they cost too much. And many times, what happens in our setting is that, like, especially now I work in transplant ICU. So, what happens is that already the patient has paid so much for the surgery and for everything. Now, once the patient goes into sepsis, it's like a huge a huge financial constraint on them
Burden.
because yeah, it's a huge burden actually. The antibiotic, antifungal, definitely because we cannot just go for meropenem here. What happens is the patient is already cirrhotic and he definitely there is antibiotic resistance. You know, you will definitely encounter one Klebsiella pneumonia where none of the drugs will be working. Even there are situations where Ceftib also doesn't work. So you'll just have to go for that simultaneous infusion, or maybe you'll have to start the third line agent as well, and then the antifungals. So what happens most of the time with me is that they will straight away come to me and they'll ask, okay, do we have any other alternatives? So can we at least provide them some free samples of what is that we can do? So what happens is that each month different brands keep entering the pharmacy. So we need to be well aware of what brand is there currently because they will just turn to you, the physicians, they just turn to you and they will ask you, okay, which brand is currently available? What is the cost? So we need to be updated. It's like we are the walking drug formulary. So it's very
Yeah,
important
we
that
need to be
we need to
updated. It is
be,
very
yeah,
important.
we cannot just entirely depend on the system as well because each time calling up the pharmacy and asking them, okay, now which brand is available? Okay, what is the cost? It's quite difficult also because we need to take decisions quickly as well. So
So
definitely, yes,
sometimes
yeah.
the another aspect in this also, like sometimes there is like lots of debate. Can we use generic drugs in critical
Mm,
care areas?
true.
So there is also lots of debate because mostly in most of the hospital they tend to use the molecular drug, like sorry, the research molecule in the ICUs rather than a generic drug, which is generally we can use in the what, but they say that the patient is very critical and we use only branded drugs only. So there's another debate which we need to consider. Can we use generic drugs in ICUs? Because if they have the same viability and there's no other issues, of course we can use. So this thing we need to, I think, balance with the critical
Mm.
care setting, I feel.
Yeah. I think we need to be truly updated on that as well. We need to know all the studies and what they say actually, whether this drug can be given as
Uh,
an alternative. A lot of new studies are there. I mean, regarding the bioavailability and everything. So I think that's another important part that we need to be truly updated. It's not just we can't entirely depend on up to date or such apps like that, but constantly being updated with articles is important as well, isn't it?
yes, yes, 100%, 100%.
Yeah. Okay, so now talking about the antibiotics and about the financial part, I think the next important part in ISO is the antibiotic stewardship and its compliance because it's another challenging thing that I have definitely faced because critically ill patients, they are on tons of antibiotics and definitely reserve antibiotics, no doubt in that. So how do you, I mean, how was it challenging for you to be compliant, they will put some recommendation forward and how was it, the compliance and the acceptance rate from the physicians? Are they any word on that?
So when I started this stewardship program, it was obviously very less, but since I had my backing from the lead intensivist, so which was a very good thing, he was all ears of what all suggestions and what all changes, and with other doctors, how to convince them to make it a more appropriate therapy, antibiotic therapy in stewardship. So he was the main driver. Obviously, we need a leadership goal, a leadership person. So he was there, and along with him, we had the infectious disease specialist, the microbiologist, also in the team. So the team was very good. We started step by step. I think so. The main thing is where you take small steps, baby steps, and then after you see those steps getting achieved, you go on to another step. So that is very keen. So first I started with the follow-ups, like why this was started, just engaging in small talks or in different conversations of knowing the reason, what was the reason behind this use of particular antibiotic. And after understanding them and seeing, comparing with what the guidelines is suggesting, what should be the ideal, and I would just pitch in this idea of how we could do it differently, and not directly trying to change it immediately.
Yeah.
So that was one way of mine. So I would use to talk them up a little bit. One
Psychological
of the
move.
strategies, all strategies, what we can use. Yeah, just striking the conversation innocently
Like,
and then putting in my idea over there
like,
and
Mm,
just quoting one of the studies, like, okay, so we saw the study, like, they say this antibiotic is better, hey, we don't need the coverage, sir, it's okay, we can manage with this can cover this much. And slowly I could see the changes. I could talk on different pharmacokinetics also, regarding loading doses also. In a couple of cases I saw that loading dose is not being implemented, and we had a implementation of extended duration. When those topic came, we used to discuss that what are the benefits of the extended infusion. And once the guidelines came in for the extended infusion, we made sure that we used to follow those things. Yeah. So
100%.
then I think so. The compliance was not 100%, but yeah, 80 to 90%, I would say.
it's never 100%.
It's never 100%.
Never.
It is
It's
an
never. Idris, how was it for you? Same
so
question, antibiotic storage.
yeah, I agree with the Devai. Like I feel with my span of 3 years of practice in antimicrobial stewardship and critical care, I can say like antimicrobial stewardship is more of relationship building and trust building first, then
Absolutely.
implementing your knowledge. Because if that doctor has trust on you, then only he gonna change. That I feel, which I have experienced, very practical thing. So when I was starting antimicrobial stewardship, it's the same thing which I have written in my paper also, that when I started the antimicrobial stewardship, it is very important to talk to the people, gain their trust. They should be aware that this person knows something regarding antibiotics which we do not know. That they should be very clear of, like, this person is a knowledgeable person. Then only they going to accept your intervention. It is not like that you are a clinical pharmacist and you're going to tell them that stop this antibiotic or change them. This is never going to happen. So you have to go, you have to talk to the people, you have to build trust and relation. Then only your knowledge will come into play, and then you can easily tell them that this can be changed. Of course, there is lots of challenges comes when changing or de-escalating the antibiotics in the critical care area if we compare with the wards. But the easy part is you can easily changes the dose. Another important thing which I want to tell here is like it is very important to check which all antibiotics passes through the dialysis and which all not passes through the dialysis, because many times after a dialysis session, lots of antibiotics goes together, all the drugs goes together at one shot to the patient, which is very harmful. So as a part of clinical pharmacy, you should know that this drug is not dialyzable and this drug is dialyzable. So you are well aware that all of these drugs can be given before a dialysis, and all of these drugs can be given after dialysis. So there is not much pressure of drugs on the patient after the dialysis gets over. So and not everything is going at the one single shot to the patient. So it is very important to keep in mind of every clinical pharmacist who are practicing in critical care, I feel.
Mm.
And of
I
course,
believe
antimicrobial stewardship, yes, yes,
ECMO circuit too. Idris, don't forget
yes.
ECMO circuits too.
Yeah, I think you are a better person to tell that.
Yeah, so yeah, that's another one important thing, antibiotic stewardship in critical care. So now combined, I mean, so as we started talking about this in the initial part itself, we said that it's like quite a challenging part, that challenging area actually, critical care. So for those who are actually aspiring to be critical care pharmacists, what piece of advice would you give? That is right from like, how to train themselves, what are the different skills they need to develop, and what maybe some references they can look into. So any suggestions on that? Idris, maybe you can carry on with that first.
So I think whoever wants to be a critical care clinical pharmacist, they should visit ICUs and observe things, learn case by case, like learn a case today and read on that case, uh, practice drug interactions, read guidelines which are specific to critical care areas, because there are many guidelines of infectious disease tells that you have to give TG cycline at this dose, but some critical care guidelines says that you have to give double dose of TG cycline in the critical care area. So you should know all of these gray part also when you are starting being a critical care pharmacist, and learn things continuously, practice things, build a relationship, take yourself as a part of team of critical care, not someone other is from a specialty part. Like you are part of critical care setup, and everyone is a team working as a team whom you should collaborate with and then provide a care. This mindset should be very clear, and antimicrobial stewardship, of course. So I feel drug interactions, dilutions, medication reconciliations, antimicrobial stewardships, making policies regarding dilution, because there's another we can do a big talk on it, but that is also very important as a part of clinical pharmacist.
Mm. And what is your opinion on this? Like, see, it's always better if we actually have adequate knowledge on this before we start our posting itself. That is now what happens is that after internship, or maybe during internship, we actually enter the ICU for the first time. So we are like, as you said, we are like clueless. We don't know what's going on there. We have no clue on what the fluids are, how to manage the fluids, and about the ECMO dosing and everything. We just actually learn it from the physicians as such. So do you think there might be something that we can actually incorporate in our syllabus maybe while doing our farm day itself? Are there any opinions on that? What do you think maybe is a better way of learning here?
I think so. Definitely, there needs to be an upgrade in what all syllabus that we have. Plus, adding all those research trials. So and guidelines. Guidelines, I think so must be there be a mention. Like for anything related to antimicrobials, they have mention of following IDSA guidelines. In critical care, we have SSCM sepsis guidelines. So a lot of terminologies that we have never heard of. But once we enter into ICU, we get to know about these and learn about more about these terminologies. Doctors talking about trials, and peptic trial, this that trial, alveus trial, safe trial, so many trials, and they are discussing, and you're like, okay, okay, you're getting this information. I just studied a simple thing about albumin. So this is very a different approach towards ICU, where you need to know about trials and guidelines. So I think so. The first thing that my intensivist asks, if you're giving us a recommendation or suggestion, what's the evidence behind it? And it needs to be a powerful evidence, probably a meta-analysis of a randomized control trials and everything. But yeah, every time we do not get that. So it is very important to develop that skill from which study that we are picking this information. There might be just case reports or case sheets. A lot of times we have to rely on those and see whether it matches with that particular case scenario or not. And I think there's a couple of books like Paul Marino, those textbooks, ICU textbooks that one can go through. I think ICCM also has one good this handbook for ICU. So all those literature search is very crucial. And I did face a lot of struggle in the initial period of mine where I didn't know. And even when I get my interns, they also are a little lost in what kind of sites, websites, or where to get this data from. So it is very important to talk with people and see what correct articles that they are using. So it's not every day you get the correct one. So it is very important to know from where other people are getting the resources from, and just sharing this information of this literature, such and guiding, I think, so the interns from the correct guidelines, the correct websites to look onto.
So, and about the research part, as you had mentioned, I mean, we need to definitely refer different research papers and trials. So, how about we as clinical pharmacists? Do you actually find time to do research, or maybe write a paper? In this, I understand you have already published a lot of papers in international publications, and you have presented posters as well. So, how did you find time amongst all these things? That how did you find time to maybe write a paper or maybe do a trial or even do a study? So how do you find it?
So, the only thing which keeps me going and helps me regular publication is like even my another paper is under review. So, like how I can do is about changing your practice. In just you have to just systemize your current practice, like whatever work you have been given. Suppose you have been given by your seniors that you should do medication reconciliation. Like, don't just do medication reconciliation. Do a medication reconciliation with a mindset of a paper. So after 6 months, when you when you compile your data, it can be published. So whatever you are doing as a practice, whatever you are seeing every day, compile it in a form of a research rather than just a data,
Mm.
which we are giving to our seniors. Better combine in a way, better, because because my another paper of reconciliation is under review. So what I had done before starting medication reconciliation, I had read several papers. So I've already done research on medication reconciliation. So my in-house medication reconciliation audit I have designed in a way of a paper only. So when after 1 year I had the data, which was not, which was of course helpful for the hospital to improve, but also is a publication. So I this is my suggestion to the aspiring clinical pharmacist to whatever practice you do with the mindset of a research. Maybe there might be many things you may not be able to publish, but keep a mindset of research. That is the one thing I would suggest. Another part, just I would like to suggest this because now this is a good time in India that clinical pharmacists not just focus on a broader term of research, but focus on a medicines like role of clinical care pharmacist, role of clinical pharmacist in suppose some kind of medication in anti-diabetic medications, role of clinical pharmacist in hypertensive medication, or to be more specific, role of clinical pharmacist in multivitamins. So it should be now, it should now, as a clinical pharmacist, now the research should come in India for a particular thing, for a specific thing to go in more depth of it. I feel this is a good time we have reached because after 10 years has passed, broader term have been covered, like role of clinical pharmacist in AMSP has been done. So what is the role of clinical pharmacist? Specific medication should be covered now, I feel, for the aspiring researchers in CP practice.
Mm. So it's just like publish what you do. So you don't just be involved in what the work alone. You need to do each and everything with the aspect or with the thought that okay, you can actually publish this thing as well. It's a very good way of actually doing two things, at once. So have you found it difficult
Yeah.
as well to find a research paper or to publish one or to actually be involved in a study? How was it for you?
Yeah, it was very difficult. It's still ongoing, so can
Yeah.
understand that how difficult it is. But yeah, to collect that amount of data, and at times you want your results to be correct. So you want
Mm,
to be statistically significant. I think so that also it's just not about publishing a paper. There's no point in just publishing a paper and two, three papers in your name, but like Idris has such a good quality papers under his name. So that also should be one of the key mindsets that one should look for. So yeah, currently also I'm working on publishing a paper, but
great.
yeah, with the statistical significance, let's see how it comes up. Yeah.
No issues. We have time. You will definitely publish a paper. Okay, so just one more last question. So now we discussed about all the clinical pharmacy aspect and how the pharmacy journey was. So according to you, now that you have all got a complete journey, would you recommend pharmacy to maybe a student who is approaching you and they're just randomly asking you, okay, so there's this thing I heard about like pharmacy. So do you think it's a good course? Should I pursue that? And also, if there are any students, maybe I don't think maybe all the students are, maybe they won't be having the right resources to actually maybe join FarmD or anything. So, any piece of advice for those who are actually struggling to maybe join FarmD? Any piece of advice that you would like to share? Idris, maybe you can start with you.
So it depends on like they are questioning in what way, in like how is they want, do they want to do farmd as part of just part of their interest or other aspects they have. So it is very important to tackle every aspects of the aspiring farmd students. So I say yes, you should go with the farmd, and you should work hard, and once you work hard, when once you develop good skills, you can be a good clinical pharmacist, and it will help you to get a good pay also. Yes, I would recommend it.
Have they? You would recommend, isn't it? FarmD.
I think so. With
So.
this role, I think so. It was my dream come true. No, I feel so. It's like my dream come true. So whatever I wanted, I've achieved it, and
Mm,
I think so. There's so many more things to learn every day, and it's a very unique field. In matter of fact, like I've seen so much of specialization people are doing in the Western countries, and I feel that if we go to that level, the healthcare Indian scenario will be a totally different thing. And there are so many gaps in our healthcare that we as a clinical pharmacist can fill in those. So it's not just like, okay, there's saturation everywhere, there's coming everywhere. No. If you see in the Western world and everywhere around, there's so many things that we still have not started. I feel so it's still in the grassroots levels.
true.
So one needs to be patient and
Mm,
try to evolve your practice as much as possible day by day. And
Mhm.
I think so it will be something in the future to look out for as a clinical pharmacist. It will be very different in coming 10, 20 years. Yeah, absolutely.
great. So I think in interest of time, you have to wind up this actually a very interesting conversation. So before winding up, I would
100%.
like to thank the speakers, Abdi and Idris. Thank you so much for your time and thank you for sharing your wonderful experiences and for providing such great insights on critical care pharmacy. So, and to all the participants, I would like to request you, I mean, just keep listening to the FCPI podcast series because a lot of different fascinating episodes are coming up and you will explore different arenas of clinical pharmacy. So, until then, stay safe and take care. Bye bye.
Thank you so
Fine.
much. Thank you so much.
Thank you so much.
Bye bye.